Buenas noches, sean bienvenidos a nuestra sesión del mes de agosto de 2025. Les damos la bienvenida en nombre de la doctora Susana Pérez, nuestra presidenta del Colegio Mexicano de Medicina Crítica. En esta ocasión tenemos al doctor Kashani, quien nos va a dar la sesión con el nombre de la inteligencia artificial para el tratamiento de la insuficiencia renal aguda. También nos acompaña el doctor José Zaragoza del Hospital H. en Querétaro y el doctor Armando Vázquez Rangel del Departamento de Nefrología del Instituto Nacional de Cardiología Ignacio Chávez. Sean bienvenidos a esta sesión. Dr. Shashani, welcome and thank you for being with us.
Thank you very much, Professor Sanchez. It's a great honor to be here. And thank you, Dr. Zaragoza and Dr. Vasquez, for a kind invitation. I always enjoy working with my colleagues in Mexico. I certainly learn more than I can contribute. I appreciate this opportunity. So my task is to talk about AI applications in acute kidney injury management in ICU and show you some case examples that we are currently implementing at Mayo Clinic. These are my conflicts of interest. The ones that are yellow are directly related to the topic of this talk. And this just to indicate that we cannot make any progress with us alone. We need to have federal governments, we need to have industry to assist us making progress in the field. These are my conflicts of interest. Generative AI is a different topic, therefore I try not to focus on Gen AI. It would be a completely different talk, and hopefully in the future we can have a conversation about that as well. In 1956, the largest supercomputers, they only had 10 megabyte capacity. They required significantly large room, 10-ton weight, and then $31,000 per month of cost. 30 years later, Cray supercomputers, they had significantly larger capacity of 32 gigabyte. They costed $30 million, and they were 2.5 tons heavy. And nowadays, we all carry computers in our pockets that are significantly smaller with lower cost, with significantly higher capacity. The utilities of artificial intelligence in the medical domain could be indicated on public health. You remember at the time of COVID, we were able to identify outbreaks and also predict how the incidence of COVID is going to be in each location. That helped us to manage our resource allocation. Our colleagues in radiology and pathology have made a significant progress using these particular tools in order to identify diseases in X-rays and also in pathology samples. In clinical trial, we are currently using it to help us to design a clinical trial, also help us to identify patients, recruit them and retain them, and then follow up with them, make sure that there are no side effects in them. Also, clinical decision support systems are helping us in order to provide better care, more individualized and more timely fashion, and all the clinical decision support systems included. In the administrative domain, it can help us to schedule patients appropriately, move patients from emergency department all the way to the ICU and the hospital and discharge quickly. They help us to bill and collect income appropriately and then provide patient follow-up. Also, they can provide us coaching. They can help us to provide better care on individual basis and precision medicine. They can help us to write our clinical notes that we are currently using at Mayo Clinic. There are specific programs that they can listen to conversation between you and your patients and convert them to a clinical note that we are using in outpatient. They can also help us to educate our next generation. They can be on time, just in time educator and teach us and assess our performance and provide us realistic simulations in order to kind of let our new generation to understand the topic better. Now, AI is a large umbrella of different machines. AI or machine learning are tools are machine mimicking human intelligence. This is the intention. In machine learning, you use algorithms to learn from data to optimize the performance. There are different types of that. It would be supervised and unsupervised. Supervised when data is labeled, and unsupervised data is unlabeled and allow us to cluster patient appropriately. The advantage of machine learning is that they learn from data directly. They work with a variety of data set sizes, very small to very large size, and they require very modest amount of hardware, so they are not very super expensive, and they perform better than conventional methods, and also they can model after nonlinear relationships. There are also disadvantages associated with machine learning tools. Some limitations that stands for traditional models can stand for these tools as well. They lack transparency and they frequently easy to overfit. So they show performance better than they actually can do. Now, deep learning is when we use complex machine learning models to utilize multiple layers of neural network in order to provide more higher performance and more understanding of the issue. They are very powerful. They can trace untraceable problems. So our eyes can identify when patients become hypotensive. These machines can identify patients that have small changes in their blood pressure, and therefore they can use those for hypertension prediction. They can transfer learning. They can be used in different data sets with a similar performance. They incorporate different data types, including imaging, but they follow some disadvantages as well. They require very large size data sets. They take longer time to train, and they also have lack of transparency. Now, there are some AI indicator applications on acute kidney injury as well. We know patients carry some data. Some of this data is from electronic health record. Some of them is from patient data itself, all the smartwatches or wearables or mobile health, health information technology or telehealth and public health. They all can generate this digital health aura that we all have around us. This digital health aura can be used in order to develop AI models for clinical practice. So in a community setting, they can help us risk stratify patients who need to be monitored for potential development of acute kidney injury, for example. They can recognize when acute kidney injury happens. They can help us to tailor response to acute kidney injury development and help patients to improve. We use a lot of AI in a clinical setting that we can help get the help from these machines to risk stratify for us, recognize disease of interest, in this case, acute kidney injury. They can help us to identify what we can do to manage or prevent progression of acute kidney injury, and also help us to improve patients with acute kidney injury. And also, after discharge from the hospital, acute kidney injury patients have higher risk of coming back to the hospital or have heart failure or other complications associated with them, and we can use AI models to identify the disease of interest and help patients to improve. Now, for acute kidney injury, we can use these tools to define acute kidney injury, detect them, or predict them. So we all know that the process of management in clinical setting is we collect data, data becomes a decision, and decision becomes an action. Data can come from different sources: electronic health records, medical devices, wearables, or other sources. This process often takes a move forward with human input. So this is us that we take the data, make a decision, and provide action. However, we can use analytics to describe patients. So descriptive models are the models that can tell us at the very beginning of an encounter in ICU, tell us what kind of patient we are dealing with. Is this patient high risk for development of acute kidney injury or ARDS or sepsis or shock? They can also help us identify patients who have disease of interest like acute kidney injury. They can tell us exactly what criteria and what time acute kidney injury happened. Also, they can help us predict development of acute kidney injury in the future. This is very helpful in primary prevention implementation for patients with acute kidney injury. Also, they can help us to prescribe or convert data to decision directly without human input. They can be used as a decision support system or decision automation that they take data all the way to action without human intervention. For example, we are using a lot of AI model in order to develop medical records that we can actually use at the bedside. So this graph shows the map of one of our ICUs. We have 215 ICU beds at our institution, and this is one of our ICUs. Each box stands for one patient. If I hover my cursor over one of those boxes, it opens a lot of information. This information includes a lot of titles. So name, gender, age of a patient, and also kind of give us a lot of scores, including SOFA score, Meow's score, COVID if patient has COVID, palliative care score, and get with the guideline score and many other scores that you can see there are room for them to be added. And also kind of shows us what devices patient is on. So this particular patient is on vasopressors, receiving ECMO, intra-aortic balloon pump, is on dialysis and mechanical ventilator being monitored. Patients do not resuscitate and is positive for COVID. Patient has been here for, and as you can see, the organ systems also are color coded. The white means that everything is okay. The yellow coded means something needs pay attention, and when it becomes red means that it needs urgent attention. Also tell us length of stay and then ICU versus PCU status. Now, if I need more information, I double click on that box and it opens additional information for that patient population. Now, going back to that graph, if look into that little circle that says 3, this is recently added to the scores of this particular tool, and this is acute kidney injury. When I push my cursor over that circle, it opens acute kidney injury details, including what criteria led to definition of acute kidney injury, and what time, and what is the stage of acute kidney injury. Now, better than that, if I go to each ICU and I click the screener, it removes all patients that do not have acute kidney injury. So these 2 patients are the only patients had acute kidney injury. One of them we were consulted as a nephrologist, so we knew this patient very well. The other one we didn't know. And so I reviewed that patient and gave the intensive care colleagues some consultations for free or recommendations, and this often leads to improvement in patient outcome. Other potential application is definition of acute kidney injury using AI. So we know that the acute kidney injury is defined based on KDIGO criteria, which is increased serum creatinine or decrease in urine output. Serum creatinine, however, depends on baseline serum creatinine, which often is not available for majority of patients. So what we did in the recent past was identify 44,000 patients at Mayo Clinic and 6,000 patients in MIMIC-3. They all had measured serum creatinine at the baseline. So we had gold standard measured serum creatinine in them. And we tried to identify or estimate based on serum creatinine using patient medical record and artificial intelligence. So these graphs, to explain these graphs, the x-axis is the ratio between estimated creatinine to real creatinine. So the ideal prediction estimation is when patients cluster around line 1. And that means that estimated creatinine and real creatinine were the same. The brown bars are what AI did, and the blue bars are estimated serum creatinine based on back calculation from MDRD, which is a very common way of estimation based on serum creatinine. As you can see, AI did significantly better than MDRD back calculation, and this held in MIMIC-3 dataset as well. Using this particular AI service was able to identify patients based on serum creatinine better than MDRD back calculation. Indeed, 7% of patients with AI model had different based on serum creatinine estimation in comparison with 25% when MDRD formula was used. And that led to less misclassification of acute kidney injury from 41% using MDRD formula to 15% in gradient boosting with 8 variable, that is AI model that we used. Now, we also can predict acute kidney injury. There are multiple models across the literature. This is what we developed along with Philips Research North America. We identified models that can perform reasonably well with prediction of acute kidney injury at least 12 hours, 10 to 12 hours before its development, with area on a curve of 0.77 for all AKIs and 0.72 for moderate to severe AKI. As you can see, when we get closer to line zero is the time that a patient already has acute kidney injury. And 24 hours before that, area on the curve or prediction is low. The reason is that often the volume of data of 24 hours before AKI development is not very significant. However, around the 10 to 12 hours before development of acute kidney injury, performance of this model improved to a certain degree in order to predict acute kidney injury appropriately. So we can gain about 12 hours using this model. We can implement preventive measures earlier, and therefore, hopefully, we can improve patients' outcomes. We designed this model that do not generate any alert after detection of acute kidney injury. So we combine prediction and detection of acute kidney injury. We remove the alerts generated after detection of acute kidney injury as well. So as you can see, blue bars shows the alerts that was sent for patients with acute kidney injury. Patients without acute kidney injury also generated some alerts, however, significantly less than the other ones. The variables that were engaged in identifying prediction of acute kidney injury for all acute kidney injury, urine output and serum creatinine were the most important ones. But when we looked into stage 2 and 3 acute kidney injury, then fluid balance, other mechanistic variables also started showing up. We not only can predict acute kidney injury, but also we can predict severe persistent acute kidney. These are patients that they do not recover their acute kidney injury. Therefore, you may want to consider early initiation of dialysis. A persistent severe acute kidney injury is associated with very high cost and poor outcome recently in outlined literature. We served as external validation of a model was previously developed in Europe. We participated with 4,500 patients with acute kidney injury stage 2 and 3, and our outcome was development of acute kidney injury stage 3 for more than 72 hours, death within 48 hours, or dialysis need within 1 day. As you can see, incidence of acute kidney injury in our institution with the other two data sets that the model was developed was almost half, but performance was significantly better. Area under curve was 0.97, which is almost a perfect test in order to predict severe persistent acute kidney injury. This model can be used in order to identify patients who will continue having acute kidney injury, may need dialysis initiation earlier. Now, about nephrotoxicity, we developed this model that is a quality assurance model. We call it hair boil model. All the red dots are patients with acute kidney injury, different stages, and different criteria of each stage. And then the blue dots are medications that are clustered around each acute kidney injury stage. So some of these drugs are expected nephrotoxins. Some of them are used when patients are very ill, for example, sedatives or paralytics. Some of them are unexpected there. And if they persistently show up, we identify those as a potential nephrotoxin, and we start reevaluating them for potential nephrotoxicity, particularly nowadays that there are new medications in ICU, including biologicals. It is important to be able to identify drugs that could be potentially associated with acute kidney injury. Not only did that, we identified every single medication association with acute kidney injury using a frequency of isolated use, the strength of isolated use with acute kidney injury, and the frequency of use together. We also identified the interaction between two drugs. So some of the drugs had more strength of use together association with AKI. That is identified by red versus yellow versus gray. So for example, when vasopressin and insulin were used together, was associated with acute kidney injury significantly more than when vasopressin was used with albumin. It means that diabetics with need for vasopressor have very high risk of acute kidney injury. Now, we also have a model that helps with dosing on vancomycin. We know that vancomycin dosing is very challenging. It's very commonly used. However, in our study, 40% of patients only ended up in a therapeutic range after 4 doses of vancomycin. Means that 60% were underdosed or overdosed in this particular study. We developed a model that can predict overdosing and underdosing vancomycin with reasonably high performance of 0.8, above 0.8. And then we developed a model that can predict and they can suggest the appropriate dose. So, for example, this is in the 52-year-old female with BMI of 25, estimated GFR of 64, serum creatinine is 1.2. This patient ended up having the vancomycin toxicity. Vancomycin target level was very high. And the scheme that the clinicians devised was interval of 12 hours, loading dose of 1500 milligram, and maintenance dose of 1500 milligram. Using our models, about 12 hours earlier, we could say patient is going to have vancomycin toxicity. And this model is able to tell us what appropriate dose we should use to avoid that. We interviewed the critical care pharmacists. 70% of them expressed very high interest. However, when we gave them cases, 78% when there was a discrepancy between their calculated dose versus AI calculated dose, they decided to go with their own calculated dose. So, unfortunately, despite the fact that we have a perception that we can use these models in action, sometimes we do not trust these models and we trust ourselves more. This is ELIA trial 2 trial was done by my friend and colleague, Dr. Wilson, in Yale. He randomized about 5,000 patients in this particular trial to assess intervention based on electronic health record versus standard of care. Intervention included the identification of acute kidney injury using serum creatinine, also identified when these patients with acute kidney injury is receiving nephrotoxins. He chose 3 classes of nephrotoxins, ACE and ARB inhibitors, PPIs, and also NSAIDs. And also kind of included a link to, or in order to change the order to avoid further exposure to nephrotoxins. What he noted was that outside of NSAIDs, the utility of use of nephrotoxins significantly decreased after implementation of automated clinical decision support system. However, the clinical outcome, which was defined as acute kidney injury, dialysis, or death within 14 days, was only improved when PPI was used less. And that indicates that potentially RAS inhibitors are not inherently nephrotoxic. They can change the function, but they do not damage kidney. However, PPIs can cause interstitial nephritis, and by decreasing the utility of PPIs, he was able to show significant improvement in clinical outcomes. There was no other clinical outcome differences, nor there was any safety outcome difference between the 2 arms. Same group did another study, CAT-AKI, which CAT stands for Kidney Action Team AKI, combined acute kidney injury alert with the CAT Action Team that was helping with the diagnosis, volume management, potassium acid-based management, and medication management. Each team included a physician and a pharmacist. The primary outcome was, again, AKI progression, dialysis, and mortality in 14 days. He randomized 4,000 patients between the 2 arms of control versus intervention. They didn't find any significant clinical outcome difference, including primary outcome. However, completed recommendation was significantly more in intervention arm, focused on general recommendation and also changes in nephrotoxicity utilization. How about dialysis? This is a project that we are very proud of, working along with the University of Pittsburgh. Is unpublished data. We identify 1,600 dialysis sessions among 250 patients, 250 patients. Among that number of dialysis sessions, 15% had hypotension and 85% didn't have hypotension. And we tried to assess prediction of hypotension during dialysis sessions using AI models. The model performed reasonably well. So 0 is when hypotension happens, and the minus 120 is 2 hours before hypotension episode. So what we noticed that the area under curve of prediction of hypotension 2 hours before is about 0.75, and this improves over time. Particularly for the last 30 minutes, we can identify patients who are going to have hypotension about 30 minutes ahead of time. So what we noticed is that when we looked into time until hypotension happens 2 hours before episode of hypotension, there is a significant difference. We can separate patients with develop hypotension versus those without hypotension. And then also, if we looked into time since dialysis initiation, 30 minutes before dialysis initiation up to 90 minutes after, at the very beginning, we were able to identify patients who are going to have hypotension. So this model was able to identify high-risk patients for hypotension. So what we did was that we identified the first 15 minutes of dialysis. We ran the model. We noticed that there are significant difference between those with hypotension and without hypotension. And we used baseline model with area under curve of zero point 0.7. We added dynamic features, improved the performance of the model to 0.8. And this model was used in order to identify high risk versus low risk, and that resulted in action. And the action was was using reinforcement learning, was an AI in order to manage patients' risk of hypotension. So reinforcement learning is when we use the machines in order to provide us recommendation based on previous experience. So, for example, if we have a simulation or physical in a physical system, or a physical system, so it's a patient or a simulated case, and this creates a state, and this state goes to clinicians or the AI machine, and the AI machine generates an action. This action would change the simulation scenario, and that would create state 2. This course continues thousands of times, and each time a machine adjusts its actions based on the reward, which means that less incidence of the hypotension, or kind of adjusts based on the disadvantages patients get whenever patients become hypotensive. Machine doesn't do that action any longer, and this reiteration continues for thousands of times until the risk of error minimizes over time. So what we did, as you remember, we had 1,600 dialysis sessions. We used the volume and risk score and actions that clinicians took. We generated 25,000 microsimulations electronically. So we used the comparison of 25,000 that was electronically data synthesized in comparison with 1,600 that were managed by clinicians. So the 25,000 was managed by the machine, 1,600 was managed by clinicians. But we noticed that the clinicians didn't do anything for 80% of patients' sessions. However, machine didn't do anything only half of the time. So significant increase in actions by the machine in comparison with clinicians. Most of recommendations by machine was increasing ultrafiltration, using fluid or vasopressors, and very limited number of patients had less ultrafiltration ordered by the machine in comparison with clinicians. What we ended up finding is that intradialytic hypotension was 1/3 when machines were used in comparison with clinicians, 15% in clinician versus 5% in the machines. And also fluid goals were achieved in 95% of patient simulated cases when we used the machine in comparison with 2/3 of patients who reached fluid goal by clinicians. Just a few words on post-AKI care. Remote patient monitoring was devised at the time of COVID in order to avoid patients needing to come back to emergency department. We are using the same infrastructure for acute kidney injury, several other diseases, including heart failure and cirrhosis. This target population is hospitalized patients with acute kidney injury stage 3 that are not on dialysis, they are local, and they are discharged home. We started in 2021, and we continue collecting some additional data. The goal was to provide safer discharge, decrease emergency department hospital readmission, and enroll eligible patients to CKD clinics. So we identify patients, we enroll them after taking consent, we educate them appropriately, we start remote monitoring them. And remote monitoring includes some devices that can measure vital signs, including oxygen saturation, weight, blood pressure, and temperature, and then ask patients 2 or 3 questions once or twice a day. And that would lead to the algorithm that we have devised in order to nurses to provide some recommendations. Some of the routine criteria for adjustment of diuretic dose we provided. Some of the patients need semi-urgent criteria. Some need to go to urgent care or emergency department, and some of them are very critical. So nurses call the patients and ask them to go to emergency department right away. Now, potential next steps for this project is using large language models, including generative AI, to generate patient communication on time, using machine learning tool to identify and predict patients who need escalation of their care to emergency department or hospitalization, and provide them a smart medication container that dispenses diuretic based on their needs. So if their weight continues to rise, their saturation goes down, gives them more diuretics, then at the time that their weight decreases very fast and blood pressure is dropping. So this would be attached to this particular system. So take-home messages. Use of AI for clinical advancement is inevitable. They are coming. The volume of work in that particular topic is incredible and growing. Digital health in acute kidney injury continuum needs further development, assessment, and implementation. And what I really want to outline is that it is important to be able to acknowledge every single federal government, industry, universities that participate in helping you in development of these tools, as it takes a village. We cannot do it on our own. As you can see, I have worked with several different universities. I still continue expanding our reach to other universities, other industries, and also federal government. We got a few grants from federal government that has been very helpful. With that, I thank you for your attention.
Bien, muchas gracias por la presentación, doctor Kashani, y enseguida tendremos en nuestra sesión de preguntas y respuestas con el doctor Zaragoza y el doctor Armando Vázquez. Adelante, doctor Zaragoza, si quisiera hacer un comentario o pregunta con el doctor Kashani.
Muchas gracias. Dr. Kashani, I have a question first. So what do you think are the first steps that a Mexican ICU needs to do in order to maybe start incorporating these predictive models or these AI models into the everyday practice?
That is really great question, because the major culprit for appropriate use of these models have been implementation phase. And in implementation phase, there are several different considerations need to be kind of worked on. One is that we really need to make sure that the institution we are working in agrees with us. I mean, institution identifies acute kidney injury as important. For example, our cardiac surgeons, we educated them that acute kidney injury could be very bad for their patients. Now they understand that very well. So they were our collaborators in pushing institution to implement these models. And then we need to start kind of building infrastructure. Part of infrastructure is training or hiring individuals who are able to use or develop these type of models. Data scientists, all the fellows and residents who need to learn how to use them appropriately, our colleagues, particular senior colleagues who need to catch up with the rapid course of development of these tools, and then IT services and the background in order to do that. One of the most important part is appropriate data. Data needs to kind of be collected and linked and appropriately used in order to curate it, in order to develop these models. Nowadays, generative AI is helping us in order to use this real-time data availability. We are trying to use this in our current practice, but short of that, electronic health record is very, very important in order to develop that. After all the infrastructure is available, the next step is to identify a small target, small tool in order to showcase proof of concept that these devices can help. So, for example, we started with detection of acute kidney injury, just based on serum creatinine and urine outputs. Very simple code that any data scientist can write in overnight. So we identified acute kidney injury. We showed that if clinicians see that acute kidney injury, they can enter it in their medical records. They can pay more attention to acute kidney injury. Then when you show benefit, then you can start expanding that beyond to the next steps, predictive models or even prescriptive models following that. So it's a process. When you get to that point, because you had to go through several different steps, disseminating what you learned from those steps to other institutions in Mexico or other countries in South America, North America is essential. So publishing what you went through, how you learned implementing is extremely important next step in order to make sure that these are globally used in helping our patients.
Yeah, got it. Thank you very much. I have another one, but I don't want to do everything. So maybe Armando has a question now. If you want to go ahead, Armando.
Yes, thank you, Professor Kashani. A great pleasure to see you again. And you were mentioning that, collecting the data was a very important issue. So if we don't have local data, in developing countries, most of our public hospitals have no digital records or files. So collecting data is a big issue. So in your experience, if someone might think of using a model which was developed in another country, mostly in a developed country, and you want to implement that, just copying the model or sharing the model, but it's not based or developed in your population, how would you think that will affect our decisions? Do you think you can generalize those conclusions to your population? Should you follow them or no? You have to wait to develop your own.
As always, Professor Vasquez, this is a fantastic question. First of all, I consider Mexico as very developed countries. I have seen how you practice, and I've seen how the hospitals in your country is, and I'm truly proud of being here because of that. You are completely right. There are a lot of places in the world, and not only in different countries, but also in each developed countries, there are areas that they do not have access to data. Now, how we can use AI in order to kind of better care of our patients? Often, AI models are very successful when they are embedded within our workload or workflow. So, for example, in our institution, if information from AI is not within our medical records, so clinicians don't see it, they have to open a different app to see it, then nobody pays attention to it. In developing countries, the first step is to help them to generate this infrastructure they need to develop that. Use of AI is becoming less and less expensive, particularly after arrival of generative AI. It's becoming less proprietary measures. A lot of institutions can develop their own generative AI tools. My son wrote. I have a 13-year-old son. He wrote an AI tool in order to lump and a disaster area lump the people who need help with those who provide help. And that wasn't that difficult. So it's becoming easier and easier because transformers are becoming more and more available. However, any data that they have, if we provide them apps that they can enter a few number of data and get a prediction, that is next easier step in order to get them in the right track. When administrators in underserved areas realize how important that is, they can potentially change. I think that one of the steps need to be made. We need to kind of work not only bottom up, not only we have to work in order to develop them and try to implement them, the top-down approach needs to be done as well. Approaching the governments, policymakers, Congress, in order to have some laws in order to mandate this type of electronic records for all hospitals is necessary. If you recall, in 2010 or 12, there were 10 to 12 in CMS, which is a provider of Medicare, Medicaid in the United States, mandated all the hospitals in the United States have electronic records. although most of them have very basic medical records, but some of them, all of them have it to some degree. And if we have these policymakers to lump the payment to the hospital to this particular development, then hospitals start moving in the right direction. So it is important to work on the advocacy of that to policymakers and governments.
I think that the big issue that also Armando says is, of course, in many countries, in low and middle income countries, we do not have enough records or data to be able not only to know our numbers, but also to can make predictive models and things like that. But I would like to ask you if you think if this technology that or the results of this analysis could be in some point we can have technology accessible to have input in the dialysis machine, for example, to be able to guide more individualized treatment for patients, like how as you mentioned in your talk about what is the best way for the patient in this right moment to give more vasopressors, give fluids and things like that to be able to make easier the management of the patient?
Certainly, nowadays, sometimes when I have no idea what's going on with my patients, I dictate like a paragraph in AI tools and ChatGPT or others, and ask their opinion. They are my friends. Sometimes the majority of time they do not have much to add, but sometimes they come up with conclusions or suggestions that it helps me. And I think that this is something that easy, everybody can access it with cell phones in any part of the globe. To the point that a part of the 0 by 25, as you know, this the creatinine measurement through saliva or use of cell phones was devised, and there are conversations to use these type of AIs with the providers at the bedside in underserved areas in order to improve decision-making processes. This is not based on each individual patient, but is based on the scenarios that are provided by the clinicians. Beyond that, I think that helping organizations like UN or WHO to help underserved areas to develop these electronic health records is very important. Electronic health records, although is not the only source of information, is important, but it's not the only one. We can use all data that is abstracted from telehealth or smartwatches or smartphones in order to provide some recommendation for the population or for the hospital. But those adjustments like ultrafiltration that I showed you requires very, very detailed information from each patient. And to kind of tell you what next steps we did already, I didn't present, was in that particular project that we collected the arterial line waveforms, and arterial line waveforms provides a stroke volume variation, and but it's a very huge amount of volume. So I have like 100 terabytes of data just arterial waveform, and that provides better prediction. In order to get to that level of sophistication, we need to have a sophisticated data set. But there are easy things that we can do in the underserved areas, for sure.
Okay, thank you very much. Dr. Zaragoza, yes.
A second question about the first theme we were talking about. Do you think that maybe this AI training has to be included into the programs of the ICU training or the nephrologists, but the residents maybe in the medical school, in the general medical school?
Right. So you have been engaged with development focus on medical education. We barely ever had a non-radiologist do ultrasonography. Now I see medical students walk around the unit with ultrasound machine. It took 10, 15 years to get there, but now is embedded within our medical record, medical education. All medical students, all medical residents, because now devices are cheaper and they are more portable, they keep it in their pocket, and the first thing you ask them, they just put a probe on the patient's chest. And surprisingly, they are doing a really good job. Same thing for AI. AI, you can be user that you need to teach the medical students, residents, fellows, and faculty how to use it to the best interests, when not to trust it, when to trust it, and how they can use it to improve patient care. We can kind of have a few champions that also not only can use it but also can develop it. What we did, I can make simple models, but I have no ability to develop very complex models with AI. I have worked with data scientists and IT individuals to develop these. Sometimes we used larger companies like Google or Microsoft in order to develop appropriate models. Then we need to train a few of us that not only we have clinical expertise, but also understand the nuances of development of these tools. Those become champion of development of AI that is usable by other clinicians that want to use it appropriately. If it is developed by engineers alone, they have their mind of their own. What they develop may not be usable by us. So it is important for some of us to gain expertise, train ourselves of how to do it. I remember first time I grabbed an ultrasound probe was my program director came in and said, it was 2005, said that I found this ultrasound machine in the back room, go and use it. And I didn't know what I'm doing. I was just looking every single organ. Then I took some courses, then I compared myself with the radiologists, and then now I'm teaching that. Same process has to happen, but more systematically by AI. We need to start from medical schools and then expand it to residencies and training programs. And then obviously some of us need to kind of learn that to teach our colleagues and also ourselves.
Yeah, thank you. Because for sure, these are tools that are got here to remain with us, right? Maybe evolve, but they won't go away.
It's just going to be more. If you don't know him now, then it's a lot harder to know him in the future because now there are every day that I think that I've caught up with the progress. Next day I'm behind. So it was a lot easier 5 years ago to learn these. Now it's a lot more complex. So anytime that we feel that we have to implement those, we have to jump in because things become more difficult if we don't catch up.
Let me just place myself for a couple of seconds in a position of being afraid of artificial intelligence. I mean, we of course promote the use of artificial intelligence, and we are just dealing with this dilemma of how to implement that in the teaching process. So let me just be against just for a couple of seconds. So what about promoting that nephrology fellows or ICU fellows are depending so much on this technology. So there's a part that can reduce the workload for the everyday task, and that's perfect. I mean, the notes, transcribing the notes, and all this, checking the indications just to make sure that there's no errors, no, in the prescription and doses. All that is perfect, but that is different if I ask the decisions to the AI, or if I ask the AI to check my decisions. So first I make the process, and then I recheck, or someone, if not a teacher, someone, the AI, is checking that my process was correct, or letting me know if I made a mistake, before the mistake goes into the patient. That's one thing. But the other thing is not reasoning and just asking the AI to do the prescriptions or indications, or to detect something that I should have detected. For example, AKI. I mean, it's just creatinine and urine output is there. So do I need someone to tell me so that I don't need to look at the files. I don't need to look at the patient, the urine output of the patient, because I'm just waiting for that alarm to tell me, oh, this patient has AKI. I mean, how do you struggle with this dependency?
Right, that's really good. Good, a few good points that you raised. First of all, you mentioned what can make our lives easier, like note writing, versus those who can help us make a decision. And it's a work in progress, but at least in US, I know that the policies are moving toward the second category, that helping us making decision requiring FDA approval, versus those that are used to make our lives easier, not much. So less scrutiny on those. You also mentioned very important notion that there are some constraints associated with AI, and this is absolutely true. The models that is developed in Mayo Clinic that has 95% white Americans may not apply to Yucatan or Mexico City with different population. There are ways that we can make sure that models perform appropriately, but there is a significant chance that some subgroup of patients are going to be deprived from the care that they are provided, because they are not represented on the models that were originally developed. Now, also you mentioned that why do we need these models to tell us AKI? So let me share you something, because when we developed the AKI detector, the simplest thing is the code was so simple. I wrote it in half a day. We ran this model on patients in our hospital, and then we went through the notes of the clinicians to see how many of these patients actually clinicians noted that patient has AKI. We noticed that 80% of patients with acute kidney injury, there is absolutely no mention of AKI in their chart. Nothing, zero. And 20% had AKI. Mostly those patients with AKI had very advanced AKI, stage 3, 2, and 3, not AKI stage 1. And the simplest conclusion was that if you implement that and you tell the patients, the providers, that patient has AKI, they can enter it in their note. One of the ways that hospitals in the United States are being paid is using mortality index. Mortality index is the predicted mortality divided by observed mortality divided by predicted mortality. And predicted mortality, acute kidney injury, when you add acute kidney injury to the list, predicted mortality goes up. Therefore, mortality index goes down because it's denominator. And using that tool, we were able to add acute kidney injury for acute kidney injury patients to the notes. And now mortality index significantly less than 1, because our observed mortality is less than predicted mortality. Predicted mortality with acute kidney injury went up. And this was the result. Of the conclusion was that the Mayo Clinic started making more money from Medicare and Medicaid. They paid us more because our performance was appropriate. We were getting dinged every year that our observed mortality is more than what we predicted. But now we are less than 1. So we are in good shape. There are applications of these models that carefully need to be assessed and monitored. We not only have to decrease the potential complication of these tools, but also we need to monitor them. It's like any other intervention you do in medicine. You start a patient on aspirin, you weigh a benefit disadvantage, and you monitor the effect of aspirin on heart disease and also GI disease, peptic ulcer disease. You always monitor these patients. We have to continue doing that for this particular tool as well.
Yeah, I understand this part, but let me just retool my previous question. When you mentioned that, I have no doubt that this is a benefit for the patients. I have no doubt. I mean, this AI will look at variables that we don't even take care of them, or we never see them, or we cannot process that in our brains because it has a huge capacity. I mean, there's no doubt that it will be a benefit for the patient. But let's say that in this just example of AKI, no, the detecting AKI, 80% of the physicians never mention AKI, and they have AKI, no. So 20% of them just look for it. 20% look for it and detect it and correctly achieve that's in that patient. So when you're using artificial intelligence, then you are, of course, reducing that 80%. But it's not that in the future, those 20% of physicians who detected AKI will no longer be, willing to detect that, because the AI will tell them if they have or not. And in the future, maybe it will be 5%. And now it's going to be 95% of artificial intelligence, and only 5% of the physicians will actually look for it, because there's someone else who will do that task. No, so maybe in training, that was my question about. In training, we are reducing the reasoning or the capacity of the students. No, so this will be a future dilemma. And it led me add another question, if I may. What about the first contact physicians? So they are in risk, no? Because maybe those things are going to be detected or triage, or in the emergency unit, or the first contact, or even on the duties, on the guards. Maybe the first decision will be made by artificial intelligence, and then the decision will be, please, nurse, call the specialist, because this patient will have a refractory shock, no, or something like that, no. So maybe the first contact is the one who is in risk for physicians. I don't know. What do you think?
So the several different points you raised, and I think that they are very important. First of all, none of the studies have shown significant patient outcome improvement. The ones that are focused on AI, particularly AKI, they all showed improvement in process of care. And the number of those studies that showing outcome improvement are very limited, because the impact of these are not designed in order to decrease mortality or decrease incidence of AKI. It just helps us to be better doctor. And it takes me to Friedman theorem, that is a promise of AI, that these computers are not to replace us, but these computers, along with us, with the scientific methodology, with our thinking process, are going to make us better clinicians. The analogy you mentioned, that that 20% are not going to kind of pay attention any longer, I want to kind of use the same analogy as a stethoscope. So I used to carry a stethoscope every day. For the last 15 years, I haven't, because whenever I need something to know about lung and heart, I put it ultrasonography probe on patient. I get a lot more detailed information by ultrasound than I can get from a stethoscope. And I lost part of my skills on a stethoscope. Same for, I used to kind of place central lines by just traditional markers without ultrasound. I lost part of my skills on that using ultrasonography, which is a lot safer. So losing some of the skills to gain more, it's a part of evolution of medicine anyway. We learn new things in order to kind of let those that are less efficient to fade away. That 20%, however, you mentioned, that 20% identify AKI when it was very severe. They didn't identify AKI at the very beginning. And that missed opportunity of 48 hours or 72 hours of avoiding nephrotoxins. And despite the fact that 20% identified them and documented that, they could have done better if they would have been warned that this patient has acute kidney injury stage 1. That was a time that preventive measures could have been more helpful. Again, I agree with you that while we are so excited about AI, it is extremely important to monitor what is happening to our environment. We need to make sure our training is appropriately designed, that everybody is conscious about potential side effects or adverse events that may happen with implementation of AI. But this does not stop this technology to advance, does not stop this technology to come to our practices. And learning those nuances, benefits and disadvantages are both necessary in our training in order to make sure that we optimize the utilization of these devices.
Okay.
Totally agree. Thanks.
You're welcome.
And I think that one final conclusion could be also that we have responsibility, not only to how our students need to learn these new technologies, but also the ethical issues on these things I think that in the future that will be some part of the pillars of these issues. So
absolutely ethical, not only ethical, but also legal, but also social. What if a doctor does whatever AI says and that harms patients? Who is responsible? Is it the doctor or is it the AI? And these are questions that need to be addressed. We need to have a global, and not only at this level of each country, but also global approach to this. And we need to have a set of rules across the globe and each country to delineate that social implications that these devices may have. They may put some populations in disadvantage in comparison with others. You remember the saga with MELD score. MELD score for years resulted in more transplantation in male in comparison with females because creatinine is such an important variable in MELD score. And creatinine is lower in females. And that resulted in many females don't get their liver transplant. So they are adjusting those. And so, of course, we need to kind of look at the ethical, social, and legal applications of these devices as well. I completely agree.
Well, it's a wonderful session. I think these questions are very interesting. And I just like to thanks to Dr. Kashani, Dr. Zaragoza, and Dr. Vasquez to join us tonight. Well, thank you very much for all of us to join us, and have a good day.
Thank you so very much.
Thank you, Dr. Kashani.
Buenas noches. Bye-bye.
Buenas noches.